Hi, everyone. Thank you for joining. So while I know this is the Massachusetts Coalition for Serious Illness Care, we know you are also all from all over the place, which is one of the wonderful things about virtual meetings. So please, if you'd love, put your name, organization, and location in the chat. Even though I know, as I said, it's still virtual, I'm so excited because we just have so many wonderful discussions lined up for today. And of course, this is the first time that we are offering continuing education units for the very first time. We're excited to be offering 1.5 AMA PRA Category 1 credits in joint providership with the Massachusetts Medical Society. These credits can be used by several disciplines, including physicians and nurses. And for all you social workers out there, this program has been approved by the Social Work Continuing Education team at the NASW Massachusetts Chapter 2. Okay. So before we dive in, I want to thank our sponsors. We could not do this work without your support. Huge thanks to all the organizations from Massachusetts, especially Blue Cross Blue Shield of Massachusetts, for providing the core operating support that really gives us the foundation to do everything that we do. Also, thanks to the national foundations who have funded our research over the years. And of course, thanks to all of you who keep showing up. Yay, thank you for being here. We are also thrilled to be officially having Michael Curry, President and CEO of the Mass League of Community Health Centers, join our Leadership Advisory Board. Thank you, Michael, and your team for making the time to engage in and support this work. Okay, so here's a quick peek at the agenda. I'm going to kick us off sharing the story of our first ever strategic plan, remind us a little of where we started, and then share with you our updated vision, mission, and core principles. Then our leadership co-chairs Andrew Dreyfus and Maureen Visignano, along with Michael Curry, will join me to share their reflections on our new direction. And we'll take questions and comments from you, of course. And then I'll be moderating a panel with leaders from a palliative care community health worker program out in California. Then Stephanie Chan, our intrepid coalition deputy director, will give an update on some of our existing projects and collaborations. And we'll close with a panel exploring participatory research models with leaders from the Community Coalition for Equity in Research, which is housed here in Boston at Harvard Catalyst. Okay, chat is on. I can see you're all chatting in there furiously. I appreciate it so much. So, jump in, share comments, questions, reactions as we go. I'll be monitoring it all the time. And for those of you on Twitter, we're live tweeting using the hashtag that's over there somewhere, down below somewhere. You can find it. Okay, so our strategic plan. So other than the early conversations that we started having back in 2015 with the founders, this is really the first time that we've ever stepped back and asked, what have we learned? What's working? Where should we focus? What is the particular role that the coalition itself can play? So over the past 8 months, we've reflected on our research, listened to feedback from coalition members, partners, and other stakeholders, and embarked on an equity-focused strategic planning process with help from the Tammy Dowley-Blackman Group. Out of that process, plan has emerged, which centers the needs and voices of the community, what patients and real people really want and value from their healthcare, and sharpens the coalition's role as a convener to ensure that everyone, especially people living with serious illness, get care that supports what matters most. At our core, we are about improving healthcare for people with serious illness. It's in our DNA, it's in our name, and that is unchanged. But we are shifting, and I want to explain. In 2016, when we all gathered for the first time in a packed to the gills JFK library, we shared our vision and the collective goals that we thought we could all work towards in different ways. Our goals were about proxy completion and discussions with your healthcare agent, serious illness communication training for clinicians, as well as health system kind of documentation skills and interoperability. Since then, we've learned a lot, especially through our research with patients and families. Over the last few years, we've surveyed about 8,000 people in representative surveys, about half national and half Massachusetts. We've also talked to more than 800 people through qualitative research platforms where we've tested concepts and language. And our findings are pretty clear. When you talk to someone about advanced care planning in pretty typical ways, share your goals, values, and preferences in case you can't speak for yourself, well, that sounds a lot to people like dying. And when it sounds like dying, it sounds like something they're not ready for or they don't want. It was even one of those light bulb moments we had back in 2019 when we realized that even the phrase goals, values, and preferences has started sounding like death to people, which kind of makes sense because possibly the only time they're going to hear that kind of language explicitly is at the start of a difficult conversation about a prognosis that isn't looking good, about treatment that isn't no longer working, about when there's nothing left to do. I mean, think about it. Why is a goals of care conversation shorthand for a DNR or hospice? Don't we have goals of care all the time? Another main finding that we've found through our research over and over again is just that all people, regardless of age, race, ethnicity, ability, health, or diagnoses, all people desperately want to be listened to, heard, believed, have their whole selves recognized, and show up in decisions about their care. And the more we learned from our research, the more we felt the need to challenge ourselves to think boldly and expansively. The health inequities laid bare by COVID really forced us to reject the status quo. So here's our vision. It's our aspiration, a transformed healthcare system that ensures everyone receives care grounded in understanding, empathy, dignity, and respect, because you can't have quality care without it. How do we know that? Because that's what real people kept on telling us over and over again. For example, when we presented people with a slew of different concepts about what their clinicians might say to them, almost everyone gravitated towards this sense of collaboration. We'll figure this out together. This kind of collaboration is, of course, at the heart of shared decision-making, and advanced care planning is a part of shared decision-making. So what our research is really telling us is that the biggest opportunity we have to improve all of these things is to focus first on those core elements that people really want, the relational dimensions of care that are foundational to any kind of meaningful communication. The sense of connection, safety to ask questions, to share what is going on, to have their current needs met, and feel secure in their understanding of what is happening and be included, really included in decisions. And when those conditions are met, then we can let considerations about future care or care when you can't speak for yourself, those can be then a natural extension of the conversations people have been having all along. So as we crystallized our new vision, we also redefined our mission. And here it is. Our mission is to strengthen communication, collaboration, and connection between healthcare systems and communities, between patients and clinicians, to support what matters most to everyone seeking care, especially people with serious illness. This is very much about how we as a coalition, our leaders, our staff, want to focus our time, energy, bandwidth, and attention. And we're refining and focusing even further through what we're calling our core principles. The first core principle is that we want to approach our work through the lens of the needs, experiences, and challenges of people who are socially, racially, culturally, and economically marginalized, people with language barriers, cognitive, intellectual, or physical disabilities, communities of color, and low-income communities. Our research has found time and time again that people who walk into the healthcare system with less privilege face more challenges in getting the connection, communication, and care they need. But the core of those needs is universal, which means that if we redesign healthcare systems to meet the needs of people with less privilege, we will end up improving care for all. The second principle is that we have to start thinking upstream about in different ways. We have to focus on programs, interventions, and solutions that can benefit all people, because there is no magic line that separates a serious illness from everything else. In some ways, this definition of serious illness is starting to work against us more than is for us, because it's creating powerful psychological barriers for patients and families and clinicians thinking we're not there yet. The care that people with serious illness want is the care everyone wants. So we have to focus on bringing those key skills and hallmarks of palliative care, for say, listening, whole person focus, inclusive of family and caregivers, balancing quality of life and mental health to all the care experiences more broadly. Doing this will disproportionately improve the care for people with serious illness. Let me give you a quick example. An exciting new quality measure, Heard and Understood, was created by many of our national colleagues and recently endorsed by the NQF, National Quality Foundation. But it's only defined for people already in outpatient palliative care. Imagine the power of that measure if we asked it of everyone. For starters, we'd probably see how much better people's experiences were if they were getting palliative care, but it also reinforces, if we did this universally, that feeling heard and understood is not only for the very sick, and that these skills are skills that all clinicians should have. So underpinning all this work is our 4 equity principles: to rebalance power, recognize and address power dynamics, to value inclusivity by investing deeply and authentically in relationships, to practice equity as a verb actively in everything we do, and to build common ground around a shared understanding of what it means to center equity. In terms of the what, well, here are our 3 strategic priority areas. Number 1, research. We heard you loud and clear. You value our consumer research, and we are going to keep doing it. Priority number 2 is investing in collaborations in Massachusetts that fit one of 3 goals: those that increase the power of consumer voice in research, quality improvement, or program design; those that support clinicians and health systems in improving collaboration, connection, and communication with patients and communities; and lastly, collaborations that prepare patients to speak up in their clinical interactions or seek out clinicians that listen. And it's not by accident we're preparing patients at the end of this list, because part of this strategy is sort of recognizing that while patients want a voice, agency, and control, the very nature of our healthcare systems is often to strip them of that in ways big and small. Clinicians too often feel like cogs in the system themselves, but we must deal with the reality that we can only empower patients so much. So we're working on developing new collaborations, and we'll of course continue to support our existing ones. You'll hear a little bit more about that later in the show. And our last priority is really about supporting the field, all you here together in Massachusetts, bringing us together, providing resources, webinars, opportunities to champion your work, connect the dots across our state. So here is the whole plan all together. These elements are inseparable from each other, and together will guide our work in the next 3 years. You can download it on the link to the left or right. I'm left-right challenged. So thank you all for your contributions to the coalition of these last many years. We could not have done any of this without you, and you are all critical to the path forward. So with that, let me introduce our leadership for their reflections of this new direction. Co-chairs Andrew Dreyfus and Maureen Visignano, and our newest member, Michael Curry. Okay, so Andrew, let's start with you. You have been with the coalition since it was just a jumble of ideas. What strikes you most about the change and evolution of this work? What's exciting you most about this new direction?
Well, first, thanks, Anna, and your team, Stephanie Chan and others, for all the great work in developing this new, for me, very energizing vision, mission, and goal statement, and for all the work you do linking the whole community here in Massachusetts and to some extent beyond our state borders to advance these issues. So thank you. You know, what strikes me is that in some ways we had to step back to step forward. And so as you described very well, Anna, we started with, I think, although they were ambitious goals, they were more modest, they were kind of contained more in the world of end-of-life care and more about advanced care planning and that kind of values, beliefs, and preferences. And that was my line. I used to say all the time, we want to make sure our care is aligned with patients' values, beliefs, and preferences. And what our research and your work and your conversation with the whole coalition membership has unearthed that's insufficient. That if we only kind of ask these questions and try to improve care at serious when people are seriously ill, it's already too late. In some ways, it's always too early until it's too late, as you educated me on. And so I think we have to step back. And stepping back means first examining, as you said, the kind of power imbalances in the healthcare system as a whole, in the patient-caregiver relationship, the issues kind of within even families sometimes about these issues, and that we have to kind of say all care, not just care at the end of life, has to kind of be guided by this idea of that patients want their voices heard and want their agency and control, as you said. So I'm so excited about it because this is what I feel I've been working on my whole career, is to make care more responsive to the needs and views of patients. And so I'm really excited about it.
Thanks, Andrew. That's wonderful reflections. I you know, there's the sort of zoom out and zoom back, the zoom out to zoom back in, I think is like, we're going to be playing that accordion game for a while and like really adjusting that sweet spot. But I think it does feel exciting. And we struggled a lot with so much amazing guidance from all of you about how to be able to zoom out without losing, I think, the focus, which was one of the big challenges. And you all have been kind of critical in helping us kind of chart that course. And we're still going to be, you know, swimming in and bumping up against the bumpers as we try to figure it out. But I appreciate that. So Maureen, you know, you have been talking about what matters most for ages. I know in What Matters to You Day and some of the courses that you've taught, and now in sort of some of the other work IHI is doing with like age-friendly healthcare system. Like how are you seeing these linked together? What's exciting you about this kind of new direction?
Well, thanks, Anna. And like Andrew, I am really excited about this new plan. I want to begin by saying thank you to you and the whole team, because I think the process that you've gone through, looking back at the progress we've made, the places we've made a difference, but the gaps that still exist, and then looking out, you're, I think, masterful at creating connections and looking at the assets and the resources we've got in the community, not overlooking those, but connecting to those. And then looking ahead at, particularly as Andrew said, I think expanding the vision from only having these conversations at serious illness times to really thinking about co-production of health and care. there's three things that make me most excited. The first you mentioned, and that is that some years ago, I read an article by Susan Edgman-Levitin and Michael Barry that said, we can't only ask the patient, what's the matter? We have to ask what matters to you. And I put that challenge out in Paris about 10 years ago. I said, don't just say, what's the matter? Ask what matters most. And when people went back from that meeting, within weeks, I started to get emails, pictures, videos, stories of the difference that it's made. As you said, we have an annual event, but we have a What Matters to You call every month where people from Australia to Vancouver, from Sao Paulo, Brazil, up to Sweden, get together and share stories, because it is changing when we think about everybody having that voice, not just when you're seriously ill. An example is that staff tell us that when they ask that question to people, this is global research, that about 70% of the time they find out something they never knew about the person. And 60% of the time they're changing their plan of care. It's making a huge difference. And so I love our focus on expanding from just serious illness, end of life, and really starting to think about shifting the balance of power. Also, you mentioned staff, and when we started to ask the same question to staff, especially in COVID time, when people are burned out and we don't have enough people to provide that kind of care, there was a worry about, oh, if I ask that question, I'm going to have all this new thing on my plate that I can't deal with. But what we found is that, again, research is showing that on average, when you ask the question, what people are asking for is doable and quickly solvable with just a few people. But when we ask the staff, what we're finding is that they also, in order for them to have the energy and the skills to ask, they have to be whole themselves. Yeah. And so we're finding that asking that question of staff, as an example, in the UK, turnover rates for RNs in ICUs went from 48% down to 13%, and it stayed that way all the way through COVID because people felt cared for and tended to. The second one is my experiences with, as you mentioned, IHI's age-friendly health system. We started to look at people healthy and ill in the older parts of their lives. And IHI's team went out and did research. They found 19 models of care for the elderly population. None of them had spread. They were all very local to different parts of the country. So they brought together all of these people and said, let's create a model that makes sense and can spread quickly. Everybody needs to benefit from this. The model, as you said, now the age-friendly system has 4 M's: mentation, mobility, medication, and what matters to you. And by creating a sensible model and bringing people together in action communities, today there are 2,889 hospitals and clinics that have already implemented the 4 M's. 1.7 million patients have already benefited from it. So I think this is a big part of that system. It's really talking with all of these 1.7 million and all the rest of people about what matters most. Patients at every stage of life, early all the way through, need to have a voice. And then lastly, I'll end with a very quick story of my own, and that is that I had the great honor of being with my sister-in-law last weekend when she passed away from cancer. And she was in the hospital in Michigan and being treated very vigorously. And one day, one of the clinicians came in and said, "What matters to you?" And she said, "I want to go home." And so we brought her home. And oddly, they live in a very rural area. There are 3 big cranes that are 4 feet tall that come and look in the window every day. They come and eat food in the yard. And as she got sicker and we had her looking out the window, those cranes started to come and look in, and they stared at her. 4 feet tall, the 3 of them just looked in at her every day. On the day she died, one of her relatives came and played the harp for an hour and a half. The music was so peaceful and calming. And then her favorite singer was Bob Seger. So we played Bob Seger for an hour. And then someone turned on their cell phone and Hallelujah came on. And everybody just stopped. We listened to the whole song and she died right at the end of it. And the cranes flew away and they didn't come back for 48 hours. It was the first time ever that they didn't show up at the window. But it was such a moment to be able to share that with her. And it's because someone said what matters and we were able to take her home. So I am so delighted and reinforced by the vision that you've been building. And I'm really, really happy that we'll continue to work on this together.
Thanks, Maureen. Thanks for sharing that beautiful story. I feel like someone makes me cry at every single one of these. So you get the bingo today. So Michael, I know hard to follow that one, but as the newest member of our group, I think, you're new, you sort of came on at the beginning of a strategic planning process, but, a lot of the things that we've talking about, I know have resonated with you along the way. Like, I guess, like what has drawn you to this work and where do you see some of those synergies with a lot of the exciting things that are happening around the Commonwealth when it comes to improving the care for people, especially with an equity lens?
Yeah, I think first and foremost, I have to start with Maureen. And like you, and I get on these calls and I choke up and cry too often, I think at times, because I take the stories to heart. And Maureen, you sharing that really touched me as I'm dealing with several family members that are dealing with cancer now. And they're trying to figure out how to navigate systems, how to deal with, in some cases, the inevitability of death. And they're struggling with the conversation, who to have it with, how to have it, and even handling their affairs. And you make me think of that, Maureen, as the blessing that you shared of how you experienced that loss. It just makes me think about my own family. So I just want to say thank you, Maureen, for sharing that. That totally threw me off of what I was going to say, but I thank you for it. And it means a lot because that's why we're here. So one is, I would echo Maureen and Andrew. Anna, you are a force in this space. And I think as I think about Andrew and particularly in the last week, I've been thinking about and talking about his legacy and the work that he's done in Massachusetts and quite frankly, the ripple effect of the work that he's done across the country. It's about being a force. Can you enter conversations and be aspirational about where we need to go? We do a good job of talking about where we are, right? But we don't often set a vision on where we should be. And we think about even end-of-life care and now serious illness care, where we can be around empathy and dignity and respect for patients. Somebody in the room has to be able to dream, right? And that dream can be turned into a reality, but it takes a plan, a strategy, it takes a conversation, it takes collaboration, and ultimately it takes funding and support. So you didn't have to ask me more than once to do this. This was a no-brainer for me. I tend to be in spaces that I call disruptive spaces. I like when people are changing things and thinking differently about things. And when Andrew reached out to me and I was excited to join this work. So, the things that stick out to me are one, centering this around the patient. I have the blessing, the honor of representing 1 million patients, 52 organizations, health centers, operating out of 300 practice sites. And we serve the whole body, the whole patient, right? Their eyes, their teeth, their mental health, their substance use disorder, their overall physical health. We try to go upstream as much as we can and deal with the conditions that make people sick. And we're there at the bottom of the stream to deal with the chronic disease and the challenges they face when they enter our healthcare system. And it's overwhelming, quite frankly.
Yeah.
Overwhelming often when you think about how much there is to our system, right? It's the medications they get, it's the diagnostics and the exams that they need, it's the providers they interact with, it's the systems that they engage, it's the languages that you need to speak to them in, the cultural competence and awareness that they expect from us when they engage us. And I think the work that we're doing here, and I'm just honored, I'm known in the NAACP work, I say this to the civil rights architects that I get to sit around the table with once in a while. I said, I'm glad to be in that number, right? Mm-hmm. And then that number of folks who are being aspirational and envisioning what the system could look like when you center the patient and you think about how do we actually treat the person to keep people healthy and to treat them when they're dealing with disease. I'm just honored to be in that group. And then last but not least, the work around equity. As Andrew's heard me say before, if not now, then when?
Yeah.
And if not us, then who? This is the critical moment in our history. We now realize that some people suffer longer and die too soon. And we can actually do something about it. And to say that our goal, our strategy is to treat everyone and lift everyone up to that standard of care, that expectation that everyone should have access to care is encouraging for me, right? I can be out here all the time talking aspirationally, but then I need people like Anna to reinforce that with a strategy around it. So I'm just glad to be here, Anna and Andrew and Maureen. And I'm going to roll up my sleeves. And Andrew, as you transition to other roles and opportunities, you have planted me firmly in this space, and I'm glad to be here.
Oh, thank you, Michael. And yes, I thank you. I mean, there's probably no more thanks that I could fit into the next hour or two for Andrew and kind of supporting me and supporting us and having Blue Cross kind of support this work from the beginning. And I guess that's sort of like next question to you, Andrew, is guys, start putting your questions if you want from the audience into the chat. I'm looking for them. It's just like when you think about these language, equity, patient-centered, like putting this as like, we have talked about this for a long time, right? A lot of these kinds of languages going around. Like, Andrew, what do you see as you're in this moment of a transition for yourself? Like, what feels different now in some of this work, and especially thinking about a lot of the ways that Blue Cross is leading us kind of more broadly, what feels different to you now than maybe when we first started talking about this quite a lot of decades ago?
Yeah. Well, as Michael said, I mean, I think the sense of urgency and the sense that we have this opportunity, this kind of opening has been created, and we have to act now. And we have to recognize that it's going to take a while, and we're going to have to take some incremental steps. So we have to think very boldly. I was thinking about something that Maureen said. I think unfortunately, efforts in a lot of these areas that try to make care better focus either on training clinicians or on kind of empowering and advising patients, family members. And I think what we're saying is you have to do it together. And if we kind of keep those two central groups, and I would include family caregivers in this too, because they play a really important role. If we keep them in the silos, it won't really work. It won't succeed. And it's that kind of connection that kind of can be magical connection, moment of empathy, moment of compassion between patient and caregiver, where they're both aligned. And so I was so happy because there's such urgency in the clinical community right now about issues about the emotional health of clinicians and burnout and things like that. But what Maureen explained to us is that asking these fundamental questions actually helps both, brings patient and clinician and family together in a way that does ultimately respect value, beliefs, preferences, promotes equity, promotes compassion. And so it does feel different. And I think we'll make a big mistake if we keep these two essential ingredients apart. Instead, bring them together, have them struggle together to come up with some of these big step solutions that we need.
I think that is so on the nose, Andrew. I think that like one of the reasons why that word connection is all over the place, it's like in the title of today's event, it's in the mission, is just sort of we have to sort of strengthen that muscle that connects family caregivers to clinicians, that connects clinicians to each other, that connects health systems to communities, because there's like so many wonderful pockets of sort of going on, but we don't always like spend a lot of time like building that muscle, strengthening that muscle. And those are just like, I mean, they're all just relationships, but they take nurturing and investment and structures that will support them just like anything else. So Maureen, I'm gonna ask you the next question. I'm looking, there's like so many questions coming in here, and I appreciate about that. I'm gonna try to look at the one that's up, but one I want to ask before I kind of go to the chat is part of this is a bit of a leap of faith, right? Part of us is saying, we're gonna maybe not exclusively focus on people with serious illness, because we know that might be the best way of improving the care for people with serious illness, right? So there's a dynamic tension there. It's a little sort of hard. does that, like, how do you think about, we've talked about this in our small groups a bunch of times before. We are sort of like, it is a leap of faith to say we kind of have to take our eye off of just that seriously ill population in order to improve the care of seriously ill. What do you think are the sort of risks of taking that kind of approach? Maureen, I want to start with you.
I don't think there's any risk. I think it's absolutely vital for our better future. At IHI, we always say we need to shift the balance of power. And that is break down that hierarchy where a doctor or a nurse will tell a patient, this is your order, go home and do this. Because we know that a big percentage of the time they don't do that. It's not what matters to them. So I think we really need to shift the balance of power, and the connection is critical. So is co-production, co-design and co-production. And if we don't shift that balance of power so that all the voices are together planning, I don't think we're going to get where we need to go. The other thing that you mentioned is that it's a leap of faith. In a way it is. However, every single day we're seeing science come out that says, when you co-produce care, when we work together to make the plan, like my sister-in-law Claudia made hers, it's not only better care, clinical care, better clinical outcomes, it actually produces less cost and better patient experience and outcomes. A great book by two physicians in New Jersey called Compassionomics is measuring the financial impact of kindness and compassion. And we actually, a small group of us from all over the world, also started a new website called Kindness in Healthcare. And we're doing research on the impact of that. So I think co-production and kindness are going to be critical. And as you said, Anna, we've got to get back and start beginning to give nurses and medical students the skills that they need and break down that hierarchy so that patients' voices are heard.
Yeah, I'm seeing a lot of people in chat being like, this is so exciting. It's so aspirational. How do I do this at my hospital? Like, where do I start? It's so big. And I'm going to like bounce around a little bit for all of you, because I'm going to say like some of the things that make me feel optimistic, that it isn't just sort of just totally pie in the sky, are things like, I'll give you an example, like Medicare Stars came out recently, and the CAHPS measures, those are experience measures, which a lot of health plans around the entire country pay a lot of attention to. Those are really driving a lot of what's important to health plans. And those are experience measures. And a lot of the things we are talking about are really driven by communication, connection, sort of care. So I think we are seeing, if we can make those dots kind of connect across the health system, like I know health systems are like shared decision-making more broadly is a really big deal for them because it's created bigger outcomes. When we start connecting these serious illness outcomes to some of these broader things, I think we have real hope in kind of embedding them and entrenching them in ways that are going to drive things forward. This is, again, that sort of getting outside of the serious illness box. Like Andrew, you know, I know this is your sort of like last couple of months at Blue Cross, but like, what do you see in that opportunity to sort of link it with things like real levers in some of the health plan space?
Yeah, I mean, I think there's an increased understanding that consumer experience in healthcare is essential. And we know the healthcare system is fragmented, it's confusing, it's scary, it's expensive. And that until we can kind of bring those issues together and help people navigate the system, we did some separate research, as I think you know, Anna, where we went into people's kitchens and living rooms and asked them, what do you want from us, from Blue Cross? And they said, we want you to have our back when we're sick, because we want you to help us navigate the system that we simply don't understand. And we're not sure we're going to get a fair shake in it. And we want fairness and equity. And so we're redesigning a lot of our systems to try to help people when they get sick, navigate the system so they have the kind of experience that we're imagining in our kind of vision statements here. So I think health plans across the country are going to pay increasing attention to the work we're doing and similar work that really supports patients in their moments of need and families.
And Michael, I'm just thinking, community health centers are some of the hardest working, most underfunded, under-resourced places in the place that are really caring for, like so many of so many Americans, so many, Massachusetts around residents. How do you see how do you see this sort of fitting in? Is it another thing on their plate, or is there ways to really think about how this is can make a lot of the work seem easier or more achievable? Like, how do you think about that? Because it is, no one wants anything else added to their plate right now.
Yeah, I think what we're trying to do in the health center community here and writ large across the country is really think about how we can provide care better. And we know that in the health center movement, born out of really this understanding of social determinants of health, we understood that you have to treat the whole patient. We understood that you wanted to give people care that was culturally appropriate and competent for them. But I think where we also are at this time is trying to figure out if we can do things differently. And I think that's what's exciting for me from a health center leadership perspective, is as I talk to the CEOs across the state, they're thinking about how can we treat our patients differently? How can we meet them where they are? You know, one of the cries that came out of the streets in the last 2.5 years that really stuck with me, and I think it applies to what we're talking about, it was nothing about us without us. Nothing about us without us. Now that may be, you know, a racial justice cry from streets across this country, but it's about patients too, right? It's about communities too. It's about families too. And I think we're in that place where now, you know, bringing some meaning to that nothing about us without us means how can we treat them better? You know, how can we provide, as you've said, dignity, respect in the treatment that we provide for them and the services that we offer them and the coverage that we provide for them. And I think, you know, when I think about the system, I think about Andrew and his role and his successor there at Blue Cross, another good friend of mine. When I think about, we have really good people at all parts of our system right now, in the hospital systems and health plans and community health centers. And to Andrew's point, there's an alignment that I see coming across all of us that we really want to accomplish this together. So to your question, Anna, I think we're all ready for change. And I think, quite frankly, your and Andrew's leadership and Maureen's leadership is a model. And I'm going to tell you, I learned something about Massachusetts when I was young, formerly working at Blue Cross, is if we can do it here, it's going to happen in other places. So what this work is doing and can accomplish, I have no doubt, Andrew, 5 years from now, folks will be calling on you to come visit, and Anna to talk about how they can do it in Ohio and Pennsylvania and in California. So I think we should be thinking big like that.
Yeah.
That this is not just about our patients here, about our subscribers here. This is about how do we change a country in terms of how we provide care. And I think, you know, of the many things I'm involved in, some of them cause me late nights and sleepless nights. This one actually gives me joy. So I'm excited about it.
Oh, you guys are the best. I'm just looking at all the questions. We won't obviously have time to answer all of them, but some of them are just so interesting and I think can be the foundation for conversations in the future. Like things like, you know, this will resonate, Andrew, with what you were just talking about, like shared decision making is really important. But what happens when physicians don't meet quality measures or because that force or like penalize them if their patients aren't following recommendations? These are really, this is about power imbalances. This is about, do you know what I mean? Like I often think about language where we often talk about like patient compliance or adherence. And, you know, one of the questions we didn't ask in our survey last year that I always kick myself, I always thought of it later. One of these questions that's really struck with us is like, we ask a question, how often are you afraid to speak up and ask questions because you're afraid to push back and it'll impact your care? But the question I wish we asked and we didn't was, how often does your clinician tell you to do something that you know you won't be able to do? And so I think it's kind of like my sense is, is that quality measurements are changing to really reflect some of these sort of like different ways of thinking and being. And I'm sure Blue Cross will be at the sort of forefront of that as like, and also because there have been problems with quality measurement. It's a pretty baby science and we're trying to evolve. I don't know if you want to expand on that anymore.
Well, no, I think we're rewriting it right now. And, you know, one of the things I'm really excited about, it's a little not off topic, but we're starting to put equity measures into what we call our value-based payment arrangements with our clinical partners. And I hope to be able to announce the first ones in the next few weeks. And I'm really excited about that because it's changing. And we've worked with the Institute of Healthcare Improvement to move about $25 million into the community to help practices think about how they do this. And some of it is foundational. They have to collect better data, and they have to start asking for the data on race and ethnicity. But then it has to move up from that to ask about preferences and ask about what you need for help with your care. And that is also often going to involve bringing family members and other friends and partners into the conversation.
Yeah, I think being aspirational about what we want those quality measures to really measure is part of the collective thing we can think about together, is part of the work that I think Massachusetts has led the way in lots of ways, and a real opportunity to sort of to shape that conversation going forward. So I think it's there is a real lever for us there to aim at and yank down as hard as we can. So we're actually about all out of time. I don't know, and we're gonna kind of move on to next. But before we say farewell to our wonderful leaders, do you guys want to say anything else before you go?
I'll just say, stay connected. We've got the potential, if we stay connected, to really shift the culture of healthcare. And I think that's the aim. As Michael said, we have to do it now.
I would just say, you showed that photograph, I think, of our first meeting of this coalition at the Kennedy Library, and we all it felt like a revival meeting. Yeah. And people were meeting people for the first time and making connections, and coalition's so important in linking people together. We don't want to lose that, and I hope to see everyone in person at the next one.
Hashtag spring 2023.
And I would say amen to Maureen and Andrew. Just glad that we're moving in this direction, and glad to be on the team.
Thank you guys for making the time and for all of the guidance and support. It's been invaluable. Thank you.
Thank you.
Okay, so now we wanted to share a reflection about our new direction from friend of the coalition, Gloria White Hammond, co-pastor at Bethel AME Church, a fellow at Harvard Divinity School, and she wanted to share a few words about the coalition's new strategic plan. So take it away, video of Gloria.
When Anna shared the outline of the coalition's new strategic priorities with me, I was so excited. All I could do was throw my head back and shout, "Hallelujah, thank you, Jesus." The coalition's vision of a transformed healthcare system has been my life's work. My confidence in the critical importance of the mission to strengthen communication, collaboration, and connection is informed by my 100+ years of field experience. 50 years as a proud resident of either Dorchester, Roxbury, or Mattapan, all of which are neighborhoods that are largely communities of color. 40 years as a pediatrician for my mostly Black and Brown families in Boston. 35 years as co-pastor of my mostly Black congregation, and 7 years leading cultural transformation on advanced care planning at our church through our Planning Ahead ministry. And I'm so grateful to work alongside the leadership and so many of you. In the 7 years that I've been involved with the coalition, I've only known you to be trustworthy partners. Now, I'm particularly excited about the coalition's interest in exploring the efficacy of employing community health workers to better address the needs of marginalized people. Because my experience with community health workers in our ministry is that they are effective, largely because their interaction with their fellow congregants is grounded in trusted relationships. That becomes a critical aspect of addressing issues of health and wellness, sickness, death, and dying. That's critical in improving healthcare for all. And again, with that being the mission of the coalition, I just want to say amen. So I'm excited about what the next 7 year holds, and with the new direction that the coalition is mapping out. And I am confident that as we continue to center communication and connection and collaboration in all of our work, we will have quality healthcare for all. Let the church say, Amen.
Oh, thank you, Gloria. Your support means so much, and we're looking forward to deepening our collaboration even more going forward. Okay, so we have 2 panels and a couple of videos coming up next. We chose these panels and these people because they are tangible examples of the kind of work we want to lean into with this new direction. And for those of you attending today for continuing education credits, we are now transitioning to our accredited educational activity. So first up, we are thrilled over the moon to be joined by Dr. Manali Patel from Stanford and the VA at Palo Alto, and her colleague and community health worker, Gerardo Villicana from Pacific Cancer Care, who are going to talk about the program they have been working together on now for more than 10 years. Manali came on my radar a few years back after she and her team published a paper on this program in JAMA Oncology. They published another one this spring, and the results are really impressive. So we are thrilled at the chance to learn a little more, look under the hood, and here they are to join us. Welcome, Jerry and Manali. Hi.
Hi, thank you so much. It's so nice to be here with friends. And then also I'm really excited to hear and to follow on with the discussion that we just heard, because I think it dovetails very nicely into the work that we've been doing.
So Manali, why don't I start with you? Can you tell us a little bit more about this program and how it started?
So it was over 10 years ago. My mom was diagnosed with cancer back when I was a resident, and I wasn't quite excited about joining oncology just because of the many issues that we saw with many patients coming into our hospital system without advanced care planning conversations, and then quickly transitioning from an inpatient setting to hospice, when perhaps these conversations could have been embraced and engaged upon much earlier in the disease continuum. So I took several years off of my residency and fellowship, clinical fellowship, and launched into a program trying to understand how to use design thinking as well as community-based participatory research methods to better improve care delivery. And what we launched was essentially many evaluations, interviews with stakeholders, including patients, payer organizations, clinicians, as to why these conversations weren't happening or why they were happening too late. And what we heard from patients was that perhaps these conversations could better be engaged upon and with other people like them. And I resonated with that because my mother also found great solace in discussing issues regarding her prognosis with people that were in the waiting room for their screening mammograms rather than their clinician and her own clinician. And so we launched this program without much evidence, had a lot of pushback, both from payers and clinicians about engaging in this approach, but did find a very forward-thinking health systems, including the VA, which is where the first paper that you described was launched, with an integrated healthcare system that paid for a community health worker to be embedded in care. We also launched a program with CareMore where there were reimbursements built in. This was long before the oncology care model. And so there were reimbursements not only for the community health worker, but also for the time that was necessary for the clinicians to engage in such work. And that led to, again, this long standing relationship with community health workers and community organizations to delve into this project.
Wow, so that is a long story, champions, payment models, like all the works that anything needs to kind of go. And that gives us the wonderful opportunity to have people like Jerry be able to do this work. So Jerry, can you tell us a little bit about like what you do, like what's special about the role that you play for the patients that you work with?
Yeah, thank you again for having me here and be part of this amazing panel. One thing that we're focusing on Pacific Cancer Care is discussing about the education. We believe it's really important for the patients to understand their diagnosis as well as the treatment options that they're receiving. We also focus on precision medicine, which is a term that not many patients are familiar with. A lot of our patients think that they're only receiving chemotherapy when they're receiving other options such as immunotherapy, targeted therapy. So we focus on explaining all of those options and how it affects them. But a big focus of our work with our patients is talking about goals of care. This is a conversation that is very crucial to have with the patients, but unfortunately, because of the time strain, providers are not able to have this conversation with the patients. We really care about what really matters most to them so we can really show that we care for them. And then that really leads us to have a conversation about advanced care planning, helping them fill out an advanced directive, which is something that patients have never heard of in the past. And if they have, they haven't had the desire to fill one out because they're like, okay, I'm doing good. Like, I don't need to fill one out. So it's definitely something that patients have not wanted to fill out at the beginning. But after having these conversations, the explaining their condition and the importance of filling one out early on has really given them the confidence and the understanding to and the desire to fill one out.
Yeah, I know what when we were sort of talking before in preparation, it seems like a lot of the things you also do are really addressing non-medical needs in connection with this work, and that's, you know, really thinking about their broader quality of life. I guess, like, Manali, we'll start with you. As your published research speaks a lot to this connection and impact on the CalSTRS, like what is about the sort of, you know, the non-medical needs?
Yeah, I mean, I actually think of serious illness conversations to be non-medical, and somehow in our medical world, these have become medicalized conversations that are supposed to be held, and they should be held between physicians and clinician and patients, but they really need to be started much earlier and can actually be non-medicalized and held even perhaps better with Jerry and other community health workers that are doing this work. There's also this aspect of essentially utilizing individuals who are trusted, you know, that have the engendered trust. Most of our institutions, I know, close your ears, but we have not engendered trust with many of our patient populations. And a lot of my work really focuses on health equity. So I was loving what I was hearing earlier about the integration of health equity. The work that Jerry focuses on, especially in Monterey County, is helping to bridge that gap between an institution that may not have necessarily engendered trust, but being a trusted individual from the community who speaks the same language, who is from and has perhaps even lived experiences as community members, to begin to build these relationships over time such that patients feel more trusted, more open to being able to engage in these conversations. And there's this lack of hierarchy. What we see also with certain patient populations, especially in the VA, what we found is that there's this yes, sir mentality of, you know, whatever you say, doc, I'll do. And oncologists, not to rag on my colleagues, but, you know, we are very tunnel visioned often, and we'll think about cancer treatment as we want to treat this cancer, the cancer is growing, the cancer is shrinking, but not thinking the holistic picture of our veterans perhaps not having homes, perhaps the difficult transportation issues that they have to engage in, and then also do our treatments even match with what their goals may be if they have a better understanding of their prognosis and perhaps what their what the side effects may be of the treatments that they're undergoing. So you know, a lot of what we do is considered non-medical, but it's extremely crucial because we've medicalized these conditions such that we are so narrowly focused on just treating cancer and serious illness, but not thinking about the person that has the serious illness and the person that's undergoing this diagnosis and treatment.
Yeah, no, I mean, I think that resonates on sort of a lot of scales. Like, we heard it over and over again from our research, which is like, they just want someone to be thinking about the sort of trade-offs and challenges holistically, as opposed to whatever particular slice of their physiology the clinician is looking at right now. Jerry, when you're talking to your clients about their non-medical needs and sort of supporting this, like, how do you see that impact their health and their quality of life and the kind of conversations that you're able to have with them because of it?
That's a really good question. One thing that, well, one of the non-medical needs that we address is just explaining to them that we're a point of contact for them. It can be intimidating to not know who to contact whenever they're experiencing some side effects from the treatment that they're receiving, or any questions about upcoming scans, who they need to call, who they need to contact. And this is where we come in to like close the gap. Even within our practice, where we have a lab, we have an infusion center, they don't know who to direct those questions. So feeling comfortable to contact us, and then addressing those concerns, just addressing transportation issues, financial assistance, connecting them to other providers, the specialists, helping arrange for some of those appointments. just being there for them has really proved for them to feel more comfortable coming to their appointments, being more active on their care, asking questions during their office visits. Like Dr. Manali Patel mentioned, patients don't feel comfortable like coming to their appointment and addressing these issues. This when they don't follow up instructions because they just feel intimidated by the presence of the doctor and not being able to explain that well they didn't understand the directions of the medications that they need to take at home. So this is where we come in and I really help explain to the patients what's going on. And definitely addressing advanced care planning early on during their treatment has proven to be really helpful, especially having a conversation about hospice, what it means, and helping them go through that process as well.
Yeah,
I think one thing that Jerry failed to mention is that he uncovered that many of our patients had food insecurity. And in interviews that we conducted, patients would say, I can't even begin to think about a serious illness conversation or a conversation about my goals of care when I need to figure out how to get food on the table for my family. And so if there was some thought of even a 2-month survival improvement with a particular drug, there may be a decision to continue with that drug rather than perhaps choosing more palliative or conservative measures due to these other aspects that are significantly important complications from social determinants of health.
Yeah, I mean, again, it makes sense. I was at a panel recently and someone was like, how do we get more people to do advanced directives? And I'm like, I think people are making really good informed decisions a lot of the time about what is most important to them. And so you have to address those things first in order to A, establish trust, and B, because showing up authentically as opposed to doing something that they don't think they need more than other things is one of those moments of disconnection and distrust that impedes us able to kind of have the conversations ongoing. So now, but these are hard conversations. I want to talk a little bit about sustainability in a couple ways. Jerry, first to you, at a personal level, like how do you sustain yourself in this work and protect against burnout?
One of the things that I'm very grateful is as part of this team, we received a visit from a local chaplain. Well, actually, it's a chaplain at a local hospital. We have this conversation with him. He comes into our practice, and then we discuss ways of how to manage the stress and difficult conversations with our patients. So it's a open, safe space for us to really ventilate how we're feeling. And that really helps to remind ourselves of the work that we're doing. Another way is just have an amazing support team. All my teammates are amazing people. Manali is really helpful in having these conversations with us, as well as the other community health workers at the practice, and just reminding ourselves that like the small acts that we have with our patients can go a long way with them. Simple call to checking how they're doing after their treatment goes a long way in them feeling comfortable approaching us and seeing that we really care about their well-being.
Yeah, that makes a lot of sense. Good teams make a difference. So Manali, obviously thinking about sustainability a little differently, how do you fund this? How do you ensure a sustainability so that we can all have a Jerry? I want a Jerry.
I do too. We're so lucky to have Jerry. I think it's always been a point of interest of mine is how to sustain these models. I hate that, we come in with our grant funding, often from institutions. We don't think about the sustainability, the funding ends, and there goes the community health worker models. And so one piece that I've really been focused on is ensuring that we have the right stakeholders at the table. So we always have a community advisory board. Even in the VA study, we had a veteran and family advisory board where we also have executives from the health system and the county that are included, as well as policymakers, in terms of if the model shows effect and there's a benefit, your goal, right? Our goal is that this will continue to sustain and that there's a commitment that is made by these stakeholders to continue the model. So we did the same approach down in Monterey County, which is where Jerry is working, where we had policymakers. And as Jerry mentioned, this actually was a study that was focused on precision medicine. So we had precision medicine funding that then integrates community health workers into engaging patients with precision medicine care. But what it's done now is demonstrated the implications of community health worker models such that policy changes can be made and there's reimbursement that is embedded now through Medi-Cal, where patients can actually and providers can bill for these services. It's still not enough. So it's $12, but it's better than zero. And what it has also done by having stakeholders at the table before we launch these programs is it also, even without the reimbursement, the clinical lead, for example, that's working with us and our community partner clinical lead had already embraced this model after the great benefit that Jerry showed, which, we haven't completed the study yet, and we haven't completed, at least for the precision medicine piece, the outcome piece. But we do 100% know that it has made such an impact that the clinical lead said, oh, Jerry's with us, right? We've got this community health worker model that's going to sustain. What I worry about is the community health workers. And so as Jerry mentioned, we built in, after doing a small evaluation of the community health workers in prior studies, we found the concern for death and dying and grief, which we all experience and I experience on a daily basis, to be quite dramatic amongst community health workers who have a unique relationship with patients. And so we built in chaplain and palliative care services to also help with burnout and concerns about grief and dying. But I also worry about retention of community health workers. This is considered mostly a transitory role where Jerry's probably going to go off to medical school and so going to leave a void for us. So how do we continue to retain community health workers and then also advance their careers, but have a pipeline of individuals that may want to go through this process of becoming a community health worker, moving on, but then there's also a unique opportunity for other individuals in the community to take on these roles. So we've had lots of turnover in our programs just across the United States. So I think about addressing turnover. For Jerry, how to provide ongoing mentorship for career advancement. The fact that he was invited for this panel really warms my heart. And also, he's too humble to say, but he's about to be awarded at the AONN conference now for being an amazing community health worker who also fills a role for navigation, among the many other things that he does. But how can I and the teams provide ongoing mentorship and support, especially when they are more sustainable models in the community? And also, how do you support patients as there are turnovers, right? Where there's vacation or time off. We want community health workers to not only be compensated for their role equitably, but also to have PTO and time off. And so that means that there would need to be more Jerrys in the clinic than just one person, and that there's some level of team-based management such that there are a covering for any sort of gaps that may arise when a community health worker may be out.
Yeah, I want to pick up on a couple of things you both have mentioned but I keep on thinking about training. And I'm thinking about training in a couple of different ways. It's sort of like, what are these critical skill sets? And I think about it in two ways also, because you guys were, I think, listening in at the beginning, is that part of the gamble that we're making right now is that if we lean into things that aren't just for people with serious illness, because it's so challenging to catch people at the right time, and because the longitudinal nature of relationships, the longitudinal nature of complex chronic diseases. So it's like, when we're thinking about, that's a two-part question. One is like, when we're thinking about these skill sets, what is a skill set that's important for people as they be, sort of like have illnesses that become serious and advanced? Like, is it really any different than any sort of like any, kind of more standard or sort of like general practice community health worker? Are there specific skill sets, or is it really just like the core of a community health worker, which is connecting with the person, connecting a person to the things they need? Like, how do you think about those buckets of skills? I'm going to talk with Jerry first, and then Manali, you can chime in after.
I feel like that's you touched on a really good point. I feel like in terms of training, there's certain basic skills that like a patient navigator or a community health worker should possess in terms of like really finding out what resources are out there in that community available for the patients, but also within the clinic. Like once again, connecting those gaps, connecting within all different departments within the facility. But also, I feel like it should be tailored for each individual facility, each individual specialty. Where, like, for example, for a primary care practice, they might focus more on like screening and prevention. Whereas here for an oncology practice, it's more about teaching patients about their treatment, starting with the basics of what cancer is, because just hearing the word cancer means they might think, okay, this is the end. But no, there's still, like, with the advancement of research, clinical trials is showing the importance and and in the education of the patient. But definitely the basic training on patient navigation, motivational talks with our patients, and it's something fundamental in the training of community health work.
Yeah. Manali, what do you think about, you think those sort of balance between the sort of generalist nature and the specialist nature? Because a lot of people are interested in community health workers for serious illness, but I would hope that we don't create more silos than we need, because one of the beautiful things about community health workers is that the way that they can traverse silos.
Yeah, so I think it's interesting because, we hire for Jerry. So it's, people say, well, do they need a particular background? Who do they need to be? There's really this service orientation that comes across when you meet people in an interview. And so, and it's kind of intangible in terms of who to hire. So there is really this natural fit for who would be right at having these conversations. And I actually think the training is more to help community health workers feel more comfortable. But I think the conversations are really just conversations, and there isn't much training. In fact, Jerry's not going to tell you, we kind of threw him into the mix. We trained him on navigation, and we did all these motivational interviewing things, and we sprinkled in some palliative care, and now we're actually really launching this PCORI funded trial where his main focus will be just on advanced care planning and also symptom assessment. So delivery of palliative care, which is usually traditionally reserved for palliative care physicians and also clinicians, where he's received more training. But I actually don't think Jerry and other community health workers that are fit for this role need that advanced level of training. They are hired to essentially connect with patients, and those conversations, even though Jerry was mostly focused on precision medicine, he would describe cases in our case conferences that he had essentially navigated people into palliative care and to hospice, and had addressed hospice conversations without having much training in that area. I do think training does help. Again, having words that work, resources, and also I think what's incredibly important, as I alluded to before, is that mentorship piece of case conferences, being able to describe issues that come up, how to address particular concerns, how to engage patients regarding advanced care planning. That's critical, but it's not your routine training pieces. And again, it's an interesting question. We have training curricula that we've created and we use, but I actually think it's more to make the community health workers feel more comfortable rather than them actually needing to have that training to conduct the work that they do.
No, and that makes really sense. And I want to pick up on the other thing that both of you sort of mentioned with some of these trials focused on precision medicine. That's clearly not advanced illness, serious illness, end of life. And we were talking a little bit before we started, a kind of transparency to the audience. I think one of the things that I didn't realize when I was looking at those papers is that those models, even though you reported on the advanced cancer patients or the people who are within the last 3 years of life, you don't in any way limit this to people with serious illness. Tell me why. And maybe do you think that's one of the reasons why you're getting such results? Because you're not putting some of those barriers to enrollment in place.
Jerry, do you want me to take this? And I'll have your thoughts about what you do in the clinic as well. I have always been of the mindset that these conversations should be like when we sign up for a driver's license and we're asked, do you want to be an organ donor? And we don't think twice about it, right? And we say yes, no, and then we get our driver's license. And so why these conversations have been so they're important, and they need to be had when you're making any sort of treatment decision, regardless of stage of disease or type of disease. I like to know what my options are and how to engage with my clinicians about my prognosis, even if I don't have a serious illness, but I may have hypertension and want to know the treatments and the side effects and what the likelihood would be of additional clinical visits on my life to be able to make decisions about whether I would want to undergo a treatment that's by pill for hypertension or come in every week for a blood pressure visit. Something as simple as blood pressure management also requires people to make decisions, and especially for patient populations who may be from communities where working is really important and employment and dutiful employment is important and it requires time out of their day. Our clinics are open mostly during business hours. And so it is inconvenient for someone to have to come in for a clinic visit and may make a decision, may make their decision, may alter their decision depending on what is required for them. Having that anticipatory guidance, I think, is really important. And yes, like you mentioned, we never limited it. We heard from clinicians because, again, we like to cater to our stakeholders. So a lot of oncologists were really worried about these conversations being held too early with patients. And so we got a lot of pushback. Again, this was 10 years ago, but pushback from oncologists, and even still now when we've been launching the PORI study, about whether these conversations need to be whether we need to wait until patients are at a critical time juncture for having these conversations. But it is a paradigm shift, and it requires us, again, demedicalizing these conversations and thinking about them as necessary to have early. And then as patients begin to develop the activation, you see this enduring effect. And even in the VA study, right, we've got patients that lived 15 months later. And what you saw was that the intervention was 6 months up front, no contact with patients after 6 months, and the enduring effect lasted. So we were hoping that perhaps even if they don't pass away from cancer, they may pass away from heart failure, and they need these skills to engage in that illness conversation. So again, thinking about it holistically from the patient's view of what skills do we need to embed for a patient to be activated in healthcare in general, as it relates to serious illness, that same skill set would be important as they are nearing the end of life. Jerry, I'm going to turn this over to you because I would love to hear your thoughts about this.
No, yeah, I absolutely agree with Manali in terms of the importance of having this conversation with our patients early on. Ideally, we would like to be having this conversation as soon as a patient is referred to our office, as soon as they're diagnosed with cancer. Just because they're at this stage in of their lives, they just found out about this. They're making a lot of decisions on their personal life, having all these conversations with family members, and just trying to understand what's going on. And we believe that at that moment, that's when they really need to have these conversations. But also, it's when they're still stable, their health condition is still stable before they start treatment, before they start experiencing all these side effects. So we want for them to make the best decision. So that's the way I try to explain it to them, the importance of having this conversation early on. And because a lot of times we just don't want to think about it. And when we discuss this with our families, it's right when we're already on bed. And unfortunately, that may be a little too late for that. And that's why, I start discussing the goals of care. What is it that matters most to them? And then after discussing everything that's going on, that's when I have this conversation. For example, really quick, I want to share a case with one of my patients who was very hesitant about talking about hospice. They say, no, I've heard from family, from friends, neighbors. Hospice is when, that's it, that's my end. But no, really talking about different hospice options. So we went through, I helped them fill out an advance directive. He brought it into our office. He shared with a local hospital as well as with some other providers. Sadly, his condition progressed, and he actually ended up going to hospice. A patient who was very resistant to the idea of hospice, we discussed, and he actually is receiving hospice services at home because he knew that he didn't want to be at a facility. He pictured it from movies, this ugly place where family members didn't even want to go. But he received a lot of attention, a lot of care. Nurses coming to their house. Family members were very grateful. They would still call me and tell me how grateful they were for our support, for our continuous communication. So even though he was already in hospice, we were making sure that they were receiving the services that they needed. And the patient actually passed away very peacefully at home, surrounded by his family members and with the attention that he deserved and wanted from our previous conversations. Yes.
Yeah, I mean, when you start early enough, you have so many opportunities to be able to kind of build relationships and kind of steer support people in their prognostic understanding. I think prognostic awareness is a really technical term, but we say it a lot, like people can't engage in shared decision-making if they don't actually know what the trajectory of their sort of illness could look like. I think that is one of the critical things that we need to do a lot better job on. And it's amazing, Jerry, to hear how much time you spend just kind of giving people the basics, going through sort of like helping them understand the ways this could play out and what that's actually going to mean for them. So I have a couple of questions from the audience that I wanted to bring back to you. One of them was just like, do you find that you need to like convince people to talk with Jerry, the community health workers versus their specialists? Do you ever get that pushback being like, oh, I want to talk to my doctor as opposed to the community health workers?
No, I feel like so far I feel like I really portray myself as someone that I'm just there to answer like certain questions, just any inquiries. I always, since the beginning, I said like I'm just a point of contact. I'll try to answer any concerns that you have, but definitely I understand my scope of service. So if there's a very technical medical questions about like, okay, how many more cycles do I have of treatment, or what medications am I taking, when to stop them, that's when I relay the information to the providers, to the triage nurses, to the correct person. But in terms of having this conversation with patients, they actually seem like someone that they really trust because I've spent so many hours talking to them, both in person, over the phone, or sometimes even over video. They love to chat over video, and just see that someone who cares and who's there, especially because a lot of our patients that we're helping are Spanish speaking. So I'm there during their office visits, there with the providers, and just the role that the providers take in terms of like introducing me for the first time. They gain the confidence that they can talk to me, and I'll first of all care for them, but also relay the information and get the most accurate information back to them.
Yeah, I think the team-based model works. We've now done this a couple of times where we've had kind of community health workers not embedded in teams, just because we've had some difficulty with some oncology providers many years ago with embracing such models and also embracing such conversations so early upstream. And what I've seen is that initially patients in those models may be a little bit more reticent to talk to the community health workers, especially if they may be linked to a payer organization, for example, or, where we found great success is also with a labor union organization, which was also the health plan. And so they were already embedded as part of chronic disease management and were trusted resources already. And so we're pretty easily accepting of the model rather than discussing with clinicians. But even where we found in the VA, where there was initially some pushback by veterans of who are you and why are you calling me, and are you with Dr. Patel, or who are you representing? What we found was that over time, because the community health worker was more accessible to handling scheduling issues, like Jerry mentioned, they then became the first point of contact for everything. And in that first paper that we wrote, it was really just focused on advanced care planning, even though we had hoped to do symptom management as well. We got from the clinicians, let's just focus on advanced care planning. We don't want to do any symptom management right now. And the community health worker then became the first point of contact for any symptom. And they would be contacted. And then it just kind of organically developed into this, you've got to address symptoms before you can engage in an advanced care planning conversation. And so it just naturally melded into a symptom and advanced care planning intervention where there were triage and workflows that had to be developed. It's a very good question, but actually we found the opposite, that once the community health workers have embedded a relationship with patients, it's hard then to have a meeting actually. And I saw this with my own clinic, that they would ask, where is Laviva, right? Where's the community health worker that was supposed to be here? Why are they not here? And I don't want to talk to you until I have her, present, or my list of questions that we had gone over that she was supposed to remind me about.
All right, we have time for one last question that I have some from the audience. It's just going to be like playing on this theme again, but it's like, it sounds like you are nuanced and flexible with the way you incorporate people into teams, the way some specialists accept them and some specialists don't. Like the actual question is, how do we change that tunnel vision of specialists to engage them more in this important work? And what I hear you saying is sometimes you can and sometimes you can't. You just do it off the side anyways.
Yep. You do it any way you can get it, because, and so we built in these models, and it will be an interesting study because I always think about what's the most effective way to embed and to approach such models. I do think that there's a lot more to be there's so many more benefits if it's embedded. What Jerry's able to do is kind of bridge this community with the clinician. And when you embed that approach, then the clinicians can actually introduce Jerry from beginning. And it's really serves as this team-based model, which I think is the ideal approach. But if you can't get there, there's so much benefit. And we're just about to publish, we hope, but we presented at ASCO annual meeting, was what you do when you don't have an embedded model. And there are some clinicians that just will never embrace non-clinicians discussing what's considered a topic that should be only reserved for clinicians to discuss. And so what can you do in those situations, and what does the model look like? Looks very similar in terms of activating patients. There's just not that dual bidirectional conversation with the clinical team, but you're helping to hopefully engage and activate patients to become their own advocate in these conversations, which then would serve them if potentially they don't have cancer, but have heart failure. So there's benefits for both approaches. And so we just do it as we can, trying to make a difference and trying to improve these models and advanced care planning conversations.
Well, we are out of time. This has been like, clearly we could keep on yammering on about this for like ever and ever, because it's just really exciting, and the different permutations that you have been involved in, like how that sort of works. And I think, Jerry, we've only scratched the surface of the sort of wisdom and insight that you bring to as you're journeying with people through this sort of time in their lives. And so maybe we'll, watch this space, hopefully come back to you and talk about it more, because I just hear so much energy about the potential for community health workers in everywhere, but in Massachusetts and in serious illness specifically. So thank you so much for joining us, and from California and New Orleans, and congratulations, Jerry. Bye, guys.
Thank you so much.
Thank you so much. Thanks, Jerry. Bye.
Okay, so that was such a great discussion. It's so nice to have the opportunity to learn from other people about things you're excited about. I hope you enjoyed it too. If we didn't answer your question, as you can tell, this is a place we are leaning into. This is the first time of many. Hopefully we'll be talking about what community health workers can do in this space. So we also wanted to highlight, you guys probably also are interested in or have maybe community health workers on your teams. And we wanted to highlight one example of a palliative care focused community health worker model here in Massachusetts. It's at Lynn Community Health Center. This work at Lynn was made possible by a grant from Mass General Brigham's United Against Racism program, and was championed by Colleen Reed, Chief of Palliative Care at MGB North Shore Medical Center. So here is a short video from that program.
My name is Lady Pimentel. I'm a patient navigator in chronic care. What I do is I teach, I help, I connect patients in advanced care planning, asking them like what matters to them at the moment, help them connect with resources, with providers, with appointments.
Por más de 20 años yo soy paciente del Lynn Community Health Center. Porque yo me enfermé y perdí mi hijo, perdí como que muchas cosas en el camino y pues y como la cabeza mía, tú sabes, tengo muchas dificultades memorial. Ella me ha ayudado en comunicarme con la gente, como por ejemplo mi oxígeno, con mi doctor primario, con las citas que se me hacen difícil. Ella ha estado ahí para mí. Ella me ha ayudado también con alguna carta que yo necesite y me escucha, siento que me ha escuchado.
When I called her the first time, it was hard to speak. She was depressed, but I said, it's okay, I'm here for you. Tell me what matters to you today. How can I help you now until you feel better to have this conversation? My patient, Marcos dos Santos, when he came to me, he was really sick. He was blind. The dialysis that he had made him feel really nauseous, really dizzy. He couldn't get up from bed. I need this, I don't have no food, we don't have no money, the landlord is kicking us, we have a bag of mail and we don't have what to do. I'm like, okay, give me your backpack. And he have 50 or 100 mails, and I open one by one. Okay, this is important, this is not important, and then I found one that is like food stamp benefit. Okay, you got $1,000 of food stamp.
Yeah, my name is Marcos dos Santos. She helped for everything, like paperwork and the applications, everything. Yeah, no, she helped a lot because the social worker is so busy because too many people.
For me, that one is important because like he didn't have anyone to help him. What would happen to Marcos? Truly, I don't know, but he was in a bad shape. He was a patient that needed everything, literally, and didn't have nothing. And then see him well, better, he can see now. He's not the same Marcos that I knew on the first day that I saw him. And I just like to have a person that can help you when you are like more vulnerable, and I think that's great.
Wow, so there's clearly lots going on and lots to learn from everyone here in Massachusetts and our national colleagues about community health workers. It reminds me of the focus groups we did with the Mass League of Community Health Centers back in 2019. One of the strongest themes that emerged from those meetings with nurse leaders, behavioral health leaders, and medical directors was about the potential for community health workers to support patients with serious illness, and it's amazing to see these models coming to life. Okay, so next up, we are going to hear a bit about our current work, and I am going to turn it over to Stephanie for that.
I'm Stephanie Chan, Deputy Director at the Massachusetts Coalition for Serious Illness Care. And as outlined in our goals, we are committed to supporting partnerships that improve communication, connection, and collaboration. So I want to give you updates on 4 of our partnerships that are in progress. But before I do that, I want to say thank you to the many, many people who volunteer countless hours with the Coalition. We're staffed by a handful of part-timers like myself, so we couldn't do this work without all of you as volunteers. We thank you for responding to our emails. We thank you for joining Zoom calls. And most of all, we hear you when you tell us what it's really like from your perspective. Thank you for sharing. Now on to the updates. Our Massachusetts Medical Schools Collaborative, led by Jen Reedy at UMass Chan Medical School, has been cooking with fire. We recently published a paper about the origin story of the collaborative. And did you see that? My name is next to Atul Gawande. That's pretty cool. But what's really exciting is that we've seen movement at all 4 medical schools when it comes to curricular change. For example, one school has a new required clinical immersion experience for first-year students. All students spend half a day seeing patients with the palliative care team. Another school has added simulation practice in breaking difficult news for all third-year students. It lowers the stakes by using patient actors and gives an opportunity for students to practice difficult conversations. The key progress here is in requiring content for all medical students. We heard loud and clear from them that being skilled in advanced communication is needed by every physician, regardless of specialty. So up next, we're looking forward to faculty development and accelerating even more curricular change at each of the schools. But if corralling faculty from 4 medical schools seemed a bit daunting, we've been working with faculty from the over 25 colleges and schools of nursing in partnership with the Massachusetts Association for Colleges of Nursing. We've got a nursing task force that's co-chaired by Susan Lysat-Hurley from Care Dimensions and Priscilla Gazarian from UMass Boston. We've conducted curriculum mapping to understand where our state's baccalaureate nursing programs stand with serious illness care. These results were recently presented by Anne-Marie Barron at the McGill International Congress on Palliative Care and by Connie Dahlin at the Hospice and Palliative Care Federation of Massachusetts. And on top of that, we're currently live with a similar survey out to the 20 graduate level nursing programs. We're hoping for a good response rate. But what's most exciting is a new resources website that just launched. In response to numerous requests from nursing faculty, we vetted and compiled a list of resources that you can incorporate into your teaching materials about serious illness care. And I know many of you are eager to hear about our work supporting the state's transition from MOLST to POLST. We continue to play a key role advising our colleagues at the Executive Office of Elder Affairs. It hasn't gone quite as quickly or as smoothly as we all wish. We ended up needing legislation to authorize this work, but it is most certainly going. A huge thank you to Secretary Elizabeth Chen, Catherine Downs, and the rest of the team at EOEA for their leadership and commitment to leading this complex and important evolution to the nationally recognized POLST program. Thanks to Eric Frummy and Ellen DePaula, co-chairs of our MOLST to POLST advisory group, and to Jane Kavanaugh, who's leading this work. We also want to recognize the many people who provided invaluable expertise and guidance as part of the MOLST to POLST advisory group. So as always, write to us with questions and we will share details whenever they come. And lastly, I want to talk about one of our newest initiatives, the Healthcare Agent Matching Program. It's a beautiful organic partnership with Beth Israel Deaconess Medical Center, Commonwealth Care Alliance, and Blue Cross Blue Shield of Massachusetts. From the Coalition's 2018 research, we learned that 40% of people who didn't have a healthcare agent said it was because they didn't have anyone to choose. So this program is designed to test a concept of matching patients without someone to name with volunteers from the partner organizations who are willing to become their healthcare agents. A big shout out to David Sontag, Amy Hudspeth-Cabell, Wayne Saltzman, and Michelle Durar, who've been instrumental in getting this program off the ground through their organizations. But hold up, we're not ready to take new patients or volunteers outside of the initial organizations yet. Stay tuned though, because we do hope to expand in the future. And while many of you may know me and Anna as Coalition staff, we work alongside a wonderful team of part-timers, including Diana Raya, Zuleika Hernandez, Yemi Hailemariam, Zamawa Arenas, Jane Kavanaugh, and Karine Davila. We are a small and mighty team, and again, none of our work would be possible without your partnership. So truly, thank you.
Okay, so that is a lot, Stephanie, packed into a small presentation. It's so exciting. I know it's actually probably the first time that most of you are hearing about the healthcare matching program, and we're going to be reporting back about that more often as it grows. It's a really cool project, and I know that the few people who hear about it are really excited to start sending in patients, which is why we had to make that disclaimer. It's just not quite ready. We're still figuring out a lot of the interesting challenges that are coming. So with that and with anything else, if you're interested in learning more about any of these collaborations or you think you may be able to contribute, write to me or Stephanie. Our emails are in the chat. All right, so our next panel is focused on participatory research, how we make sure that our research is asking the right questions in the right way to support care models and innovations that matter most to people with serious illness. And we happen to have a particularly cool example of a program designed to bring community voice into clinical trials right here in our backyard, the Community Coalition for Equity in Research. This project was spearheaded by Karen Emmons at the Harvard School of Public Health in collaboration with none other than Michael Curry. And we are thrilled to have leadership from the program here today in a discussion moderated by Karine Davila, who many of you will remember from last year. She is another of our wonderful coalition part-timers, though her real job is as a palliative care clinician at MGH. All right, over to you, Karine.
Thank you so much, Anna. We are incredibly excited to have leaders from the Community Coalition for Equity in Research with us here today, as it's so important to be hearing about some of the great work that they are leading to integrate community voices in research, starting more upstream. And so, you know, as some of our, we've been hearing on the prior panel, there's really a known history of what I would call justified mistrust from community members in the medical community, and in particular in the research community. And Congress passed legislation in the early 90s to really increase diversity and inclusion of historically marginalized communities in research. But many studies since have shown that there's really limited impact of this legislation, seen again, kind of, you know, most recently in these COVID-19 vaccine trials. We're delighted today to have with us Rebecca Lee, Albert Pless Jr., and Carolina Trujillo. Now, just a quick note for everyone, there may be some confusion given both that the Community Coalition for Equity in Research and our own organization, the Massachusetts Coalition for Serious Illness Care, both often use coalition in brief, but in this segment, coalition will be referring to the Community Coalition for Equity in Research that our invited speakers help lead. So I'm first going to turn it over to Becca Lee, who will introduce and share more about the coalition's work. Becca.
Great. Thank you so much for having us today. I'm really excited to be able to share this with my co-chairs, Carolina and Albert, who really helped lead this work. So you can go to the next slide. So I just wanted to ground you in where this is all coming from. So the Community Coalition for Equity and Research is based at Harvard Catalyst, our clinical and translational science center here, where our aim is really to increase the pace of adoption of evidence-based programs and policies. We try to align all of our work with community identified needs and interests, and the coalition is just one of the activities that we have towards that mission of our community engagement program. We also work collaboratively with partners across the state and are really interested in increasing the pipeline of well-trained individuals. And for the coalition, that means everything from junior investigators who might be starting their first study to a senior researcher who's never done community engagement, but realizes if I want to build equity into my work, I need to learn these skills. And so really the coalition embodies all of the main goals of our program. Next slide. The other thing I want to ground us in is this continuum of engagement. And we really believe at our program that community engagement isn't this yes, no. It's really, you can be engaging at different levels with different studies. And we want to be bringing people in the door who aren't doing the most community engaged stuff and really push them along. So we will take all kinds of research. We can take studies that really truly understand their community and they need a little extra guidance, or we can take folks that are earlier on in their journey towards community engagement and equity that are maybe in this more inform and consult area where they're just dipping their toes into engaging with communities. I see the coalition as fitting really in this yellow box where we have bi-directional communication between our coalition members and our researchers that come to us with their pressing research projects. Next slide. So the Community Coalition began when we, during the COVID pandemic, we realized that researchers were coming to us really too little too late with issues of recruitment in their studies. This is something that had always been a problem, but really just ballooned during the pandemic. And so we realized there was a need for a source of high quality community input on research and trusted and trustworthy community partners who can share input on trials with their community. So our solution is this standing trained community coalition. This is one of the major things. It's a group that comes together and is cohesive over a 2-year period. They commit to this work. And so it isn't just a one-time experience. It's this collective group that power has been amazing. And you'll hear from that later. And they provide feedback on research that really is focused on equity, as we've said, using community engaged research principles. Next slide. So there's 14 members of our coalition in this first 2-year period. We have co-created a health equity review rubric that really guides each of the reviews that we have researchers bring to us. We've conducted 14 reviews to date, and the types of research we've seen have been all over the board. So we've seen genetic studies, we've seen cardiovascular disease studies, mental health, COVID-19 in the very beginning. And we've engaged with researchers with varied years of experience and really started with postdocs all the way through those senior researchers across all the Harvard major teaching hospitals and Harvard Medical School, Harvard School of Public Health. We've received very positive feedback from all the researchers in our evaluation, and also from the members themselves. So we've collected data from the members to make sure it's a meaningful experience for them. Next slide. So this is just a snapshot of what we mean by our rubric. So our rubric is broken up into 4 different categories: the planning part of a research study, the recruitment and consent, the participation, and the dissemination. And what I've included here for you is just some exemplar items from that rubric. I found that this is one of the things that people want to sink their teeth into a little bit more. Really what we have people do is review a video and a 2-page description of every study before it comes through. And they're able to fill out this rubric to prepare themselves for a conversation with the researcher. Next slide. So finally, I want to show you all the smiling faces of who our coalition members are. You get to hear from Albert and Carolina today. You've heard from Michael earlier today, but it's an amazing group of people. We are statewide, which is really important. We're very racially and ethnically diverse. We come from public health and medical settings, but also from outside of the healthcare sector. And I think that's really powerful to have those different voices. You can see a lot of age diversity, LGBTQ folks, immigrants, local health department staff, just such a range of experiences. And with that, I'm going to have you hear a little bit more from members of the coalition in this brief video.
The Community Coalition for Equity in Research is a group of individuals we brought together from across the Commonwealth to help our researchers really think deeply about how they can bring more equity focus into their research.
It's about pulling people together to come to the table with their lived experience, with their insight on the communities that they live in and they advocate for, that they fight for, and then having them at the table with researchers.
The coalition comes together once a month. We have about 14 members. They review research in advance, so we ask the researchers to prepare a brief video. We have a fabulous facilitator who helps us kind of coordinate each session. And the coalition members take turns being reviewers or being observers of the review process.
When I think about the work I've been doing for 25 years almost with Black boys and men, I think it's a bridge there that I can create.
We come from different backgrounds professionally, different backgrounds racially, and we are in different fields. So that creates some opportunities for researchers to have diverse feedbacks and diverse recommendations how to improve on their research.
It's refreshing to hear so many other perspectives and to really reinforce the fact that nobody is the owner of the truth as a whole, that we all have a piece of it and that collectively we're much better than individually.
The coalition is a community voice.
The thing I would want researchers to know is that you shouldn't be afraid to do it. It's different to have scrutiny of your colleagues and your peers, right? So folks who've been immersed in research, who speak your research language, evaluating your approach to this particular project that you have. It's a whole other thing when you come to the community to be part of that process. I think what they will find is that there's as much value in the community as there is in their colleagues.
It's not that it's a nice thing, it's an essential thing. And I think the researchers that have been working with us have really started to feel that and realize that. And I hope more and more will understand the value that this brings to their own science and the impact they can have.
Wow, what a really great overview around such valuable contribution that these voices can bring to make research better and more inclusive. In fact, here at the Coalition, we've been so inspired by this work that we think there would be real value in using this as a model to create a similar group for serious illness care related research a little bit more specifically. Just think about what it would be what an awesome resource it would be for researchers kind of out there in the audience really looking to improve serious illness care. So now I'd like to welcome fellow co-chairs of the Community Coalition for Equity and Research, Albert Press Jr. and Carolina Trujillo, to our virtual stage. And I'll just ask them to introduce themselves as well.
So hi, I'm Carolina Trujillo, and I am the current executive director at Citizens In. It's a nonprofit in Peabody, Massachusetts. We deal with housing insecurity and food insecurity. Pretty excited to be here today with my fellow co-chair and talking about important issues that affect all of us. So.
Good afternoon, Albert Pless. I'm the Director of Diverse Equity Inclusion for the town of Andover. For the last 20 years, I worked in public health at both Boston Health Commission and Cambridge Health Department, working with communities of color. So I'm excited about also sharing the stage with Carolina and Becca about talking about the coalition. So I'm excited about that.
Yeah.
Great. Thank you. And so I just love to kind of kick off a conversation, and for other folks too, as you hear this develop, if there's questions that pop up, please feel free to drop them in the chat. But Carolina, I was hoping to start with you. Can you tell us a little bit more about who makes up the coalition? You know, we saw some of the faces in the video, but if you could share more about, you know, why is it important to bring together people from multiple identities?
So it's very important because the work that we are trying to do is really have that voice of the community represented. The coalition is a statewide, and it's basically designed very intentionally that way. And we have people from all backgrounds. We have activists, we have people from media. When I started in the coalition, I was involved with Essex Media Group. So that was the background that I was bringing to the coalition, and leadership, Latino leadership in the North Shore. People from public health, people who are activists, people who are educators. And I think that all of that was intentionally put together in order to be efficient in our perspectives. Everybody has a very different perspective that they get to share on the same issue. And I think that that's the richness of this coalition, that everybody gets to have their voice. And at the end, the goal is to have the community represented as broadly as we can have it, and have that community engagement piece and bring voice to the voiceless, which in most cases, as we've seen historically, it's been minority groups, disenfranchised groups, underserved groups, which coincidentally are our people, the people who are in this community coalition. So I don't know, Albert, if you want to add anything to that.
No, I think you covered it. I mean, I think that's pretty much who we do represent with intentionality around representing those groups. I think that's the intent, to make sure those groups are represented, that we reflect the community that oftentimes marginalized and unheard. So yeah, I would just echo that. I think that's the intent of the coalition.
And something else that I wanted to share is that every like most of the work that it's done is very siloed. So the state has been divided, and people from the North Shore don't necessarily speak with people from the South Shore, and people from Boston are very Boston centric. Cambridge feels very affiliated to Boston through Harvard. So all the work they do is really either centric to their city, Cambridge, or just focusing on Boston. And I think that one of the goals of the coalition was also to bring all of those parts together for a common goal. So I think that, you know, it's interesting. When we had our first meeting in person, we had to pick a central location to meet, right? It was the equitable thing to do. Well, I had to drive 2 hours to get to the central location to meet. That's how spread out we are. So it's very telling. I didn't like to drive the 2 hours, but yet there I was.
Oh, thanks for sharing. I can't imagine anyone loves driving 2 hours, but I'm glad if it had to be equitable, at least it's kind of, you're creating your 2 hour circumference for everyone to join and participate.
Absolutely.
Becca, I was hoping to turn to you. Can you share more about how were group members recruited to the coalition? And, Carolina touched on this a little bit, but, what were specific kind of voices that you felt were really important to have represented as you kind of, as you and the group envisioned and really created this core group?
Great question. So we began recruitment 2 years ago, just about to the week, because we're just about the end of our first 2-year term. And the first time we did recruitment, we had this statewide focus that Carolina is talking about. I was really interested in making sure we had people as I said before, from inside healthcare and public health and those outside voices. I have to say, I didn't know some of the different sectors who would hear about us and come in and be those outside voices. So it was a pleasant surprise when I saw some of the applications from people who were coming from organizations that like I'd never really heard of or thought of. So I think we had a very broad net. We really recruited through our networks of community partners, not through our networks of academic partners. I think that's an important thing. I did have a few academics apply to be on the coalition, and I said, no, you're not who we're looking for. I'm so excited that you care about this work, but we're really looking for people who don't have that academic hat. And that is different than what most people think of. So really, I will say Albert was part of a community training program that I run here at the School of Public Health called Leaders in Health. I heavily recruited through that group of people, and then the people they knew, that really helped out. But it was really thinking about who are our connections, who are the 3-4 steps removed, and doing very broad outreach. And then once we had those applications, being very, as Albert said, intentional about, okay, how many seats do we want to have in each section of the state? And then how do we want to make sure that we bring those different diverse people together and create a cohesive group? I think that was an important thing as well. So just the intentionality of those first few meetings and that recruitment being something where some people in the room were going to know more than half the people because they're super connectors people, and some people probably knew nobody. And so how do we create that as well? So I think that was also a really important part. The other final little thing that I just want to make a plug for is age diversity is something we don't talk about very much, but I love that we have people from their then early 20s, I think now mid 20s, because we're a few years later, all the way through retirement. And I think people bringing in different lived experiences has been super helpful for getting different perspectives on research, because people are thinking about different types of participants. And I thought that was important in the beginning, but became even more important.
Thanks so much for sharing that. And as you're talking, I'm seeing actually Stephanie popped in the chat. Is there a moment to plug? Are you in recruitment?
Yes, I wasn't sure if I could plug that yet. We are looking for new members. I will say I'm pleasantly excited to say that all of our current members who are coming to regular meetings, a few people had to roll off because of grad school and new jobs, but basically everybody has decided they want to come back for another term. So that means we have just a few spots for the people who have rolled off over the 2 years. So we'll have maybe 3 to 5 new members. I think coming up, our application is live on our website. I can make sure that the link gets put in the chat because if you do know people who would be interested, we'd love that.
Wonderful. Thanks. Yeah, I think definitely incorporating more and diverse voices into the work that you're doing. A question for you, Albert. What has surprised you most about the research that you've reviewed, or perhaps about the researchers that you've met kind of in this coalition work?
Yeah, thanks for the question. And I'm just going to piggyback a little bit. Well, I'm actually going to just answer a little bit of what Rebecca was getting to around the coalition itself. I think one of the, and it may have been mentioned by Carolina too, this richness of the coalition itself is its own culture in terms of, that coalition, which again, the power of having those who have worked in healthcare and those who have not, really being able to challenge each other really to make sure that we are in the best place in terms of our learning space. And so some folks who have done research before, work with researchers, really helping to educate those who have not, and really vice versa. So really, I think that culture is something that, as strong as that coalition is, it makes the work that we're doing research is that much stronger, and then that in the community much stronger. So I just wanted to kind of make that plug. But I think what surprised me, I think is, I think that we have had, as Becca kind of mentioned, just a range of researchers that have come before us, and someone who's worked in public health for over 20-something years and have interfaced with researchers along my journey. I think often, I know that a lot of researchers are trying to center equity in their work, and they just don't know how to do it. And so I think that really giving this portal for researchers to kind of come share with the group to really be able to say, how can I do this best with communities that I want to do it with, best? How do I do that? And so I think that that's been attractive to researchers out there, ranging from, as Becca said, those who are, kind of working on, seasoned projects, or those who are just on the front end of a project. We just had a researcher that, for example, was on the total front of our project with an organization that we just were totally surprised as a coalition that they came to us, but they were such the early stage of thinking through who their community was, thinking through kind of the best approach. They didn't even have a dissemination plan. They didn't have all these things laid out, but they were leaning to us to help them develop this. And that's kind of where the power of this coalition exists, where we can take researchers from whatever spectrum they're at. If you've already flushed through your materials, you have your consent, you have all your dissemination plans, we can help you be able to think about what's the best way for that to actually now translate to community. And then in early research and thinking through kind of who your target community could look like. So I guess in a third way, I guess I'm saying that, we've had a lot to come before us. I don't think I was so much surprised. This last researcher came to us, I was a little surprised about that in terms of like,
I was very surprised about that one.
that was a great, right? That was an interesting one, which challenged us, I think, as a coalition to think about, look at the reach that we can have in community. We think about, kind of like being able to help inform this organization to actually do their work in a broader way. So again, I'm not speaking to that, Rebecca, because I'm not sure if we can, but I think
you can.
We can. It was the Census Bureau, and the Census Bureau came before us as a researcher thinking about how they could look at the underreported and how that impacts services that go to particular communities. So really thinking with us around how the best way to make sure that they're addressing that underreported and its impact against a broader community. So that surprised me first as the researcher, the Census Bureau, and really and how they came to us, but also just being able to think about that type of research. It's not typically the traditional research that we may have seen through our portal. So again, I was long-winded, but I just wanted to say that was really probably Calais, the thing that probably surprised me most.
Wow, that's so interesting. The breadth as you're reflecting of kind of where you're able to have and create influence. And you touched on this a little bit, Albert. I wanted to follow up that there's obviously researchers can be at many different stages in their own work. And it sounds amazing that you're able to kind of provide feedback. It seems like at different stages for researchers. Do you find, is there kind of an optimal time that they might be able to connect or be able to kind of, really have the richest consultation and engagement experience with the coalition?
Yeah, and I'll jump in with a question. I would love for Carolina and Becca to jump in with this one as well, because, I think obviously, we want to best work with the researcher on the front end of their project. So when they have, they may have just kind of designed some of the materials, they may just be really in that beginning stage. I think that's when we can begin to feel like we have the most influence on them. I think when things are already fleshed out, it's a little harder to really be able to kind of pull some things back. So I'll just pass it to my colleague, but I think that's where I see the best influence at early stages.
So we've noticed that the further along you're in your process, and if you already have an IRB approval and all that, there's going to be a lot of difficulty of you coming back and changing protocol if you already have approvals done. So we've noticed that the sooner you start working with the coalition, really pointing out the things that you can they can actually enhance your proposal to gather funding, right? To secure funding, and also add things that it blows my mind, the assumptions that some researchers have about the community and how they believe that they're going to come in and they're going to be these white saviors or research saviors, and everybody's going to want to talk to them just because they're from an organization. And that couldn't be more far from reality, right? And you do have to make sure that you have, stipends included in your budget, that you're really thinking about language capacity, that you're really, we have a coalition member who's Asian, and I always say, she always brings the greatest perspective about the different languages that she has in her culture. Like, so what, have you looked into the data and see what community is there? Because you're talking about Asians, and there's like 10, 14, 17 languages within that community. Same with Latinos. Spanish is the same, but Latinos from Colombia speak very different than Latinos from Guatemala and from Dominican Republic. So how are you going to build your materials? Who's going to help you and support you to do that, to be sensitive and culturally sensitive? Like all of these discussions come as part of the conversations that we have with the researcher. And the sooner you can get to that, I think the better hashed out your project might be, and the more interesting, I believe, to any funding sources you might have, because you're really taking that equity lens and putting it to every aspect of how you're going to be engaging in community. That's our belief, and that's how we go by it. Of course, if you're we had a project that came in initially, embedded all the comments. Now he's been approved. Now he came back and said, all right, this is where I'm at. Now I have to develop materials. How do I do that? What is the best practice for this? And then some of the coalition members have been really interested in the work, because that's the other part. There is a component that if you're interested in this topic, the researcher gets to invite you to be part of that research, like, an advisor to that research. And there are some coalition members that have been advisors to some of the researchers that, are conducting these things. So I think that that's another huge win for the researcher, that you get to engage with experts in the field who are going to help you and lead you through whatever engagement plan you have with community. So.
Wow, that's so amazing and so interesting to hear too, that you can kind of engage with researchers at different stages. Kind of, it sounds like once they're connected, they're in and can leverage, help and leverage the resources and knowledge of the coalition to really help them kind of, from early to later on, to make their own research richer, more equitable, more inclusive.
Mm-hmm.
Carolina, I wanted to ask, you mentioned language, and I think that's so important. And I'm just, curious if you can share a little bit more about, in what ways have you seen that language is such a critical component of the research that you've reviewed?
So language plays a critical role when you're talking about cultural sensitivity. And if you're talking about, depending on where you're going to conduct your research, you have to be sensitive of what the community looks like. What is the makeup of the community? And your materials have to reflect the makeup of the community, from engagement all through consent forms, through everything else. So even when you are doing the research itself, so you have all these materials, you're out there, and now you're engaging with people. You have to really understand what the background culture is. And I think that in what we've seen is these are some of the things that we have emphasized to our researchers. You have to find people in the community that can help guide those conversations, that can be your gatekeepers, your champions, that can help you have these difficult gathered of information with people who want to participate and they feel comfortable. So language plays a significant role within the intervention itself, from the beginning, from recruitment phase, all the way to delivering results, because that's the other part that, we emphasize with the people who have been, who have brought their work in front of us. Since we are the voice of the community, we have to make sure that it's a transactional approach, that the community is going to win as a result of whatever work. And if you didn't think of that, we're bringing it to you. We're volunteering the information. All right, now you have all this information. Great, you got all this funding, or you got an A in your project from school. What's in there for the community? How are you going to disseminate your information, your gatherings? How is that going to transform into any change in the community? And I think that that's another part of this coalition that's very particular to it, that we are all, in a way, are leaders and activists for our people. And we're not, we're unapologetic about it. And we are very open to researchers and say, you know what, I'm here to think about this last one, the Census Bureau one. There was a lot of history there, and people were very open about their experiences with the Census Bureau from going back to the 50s and 60s. Some member was talking about that. And I was pretty open about my concern for undocumented people and how the government just flips on this community however they want, depending on the administration. Like DACA is a clear example of that. So those are conversations that are difficult. But at the end of the day, I want to make sure that I bring that to the coalition. And I want to make sure that the researcher has that as part of the work on how he's framing or she's framing the intervention to gather data or whatever it is that they want from the community.
I really love that. And I really love the point that you're making that, obviously in many ways, this is a resource for researchers, but it's also turning back and making sure that researchers are focused on kind of the greater purpose. It's not about kind of getting the grant or submitting the paper. It's what are we doing this for? And how are you designing the work that you're doing to ensure that it's going to have the lasting impact on the community that you're trying to help?
That is so beautifully said, Karine. Thank you so much. That's perfect. That's exactly what we hope. That's what we aspire to do.
Wow, that's awesome. So I'm already getting some questions from the audience, and one of them I do want to go ahead and bring to the group here. It really, it seems like this could be a very valuable process for any kind of quality improvement initiative or even program implementation, separate from what we might call kind of classic research. Do you review things like that, or are there any bounds to the types of researchers or projects that you're willing to hear?
I'll jump in first and say, so far there have not been bounds. If people are interested, they come to us first for kind of a mini meeting to see if their project is well aligned enough with the types of feedback we give. And then I think we're really open. And so this last example that we gave was pretty different than most of the other research we've seen, but I think you're right. A lot of these concepts could really be woven into evaluations. We've thought about also working with local health departments or nonprofits. They're doing evaluations of their own work. That's not capital R research with an R01 or something, but we can really help with our rubric in lots of different ways. So right now, there are no bounds from my perspective, but anyone else?
No, I couldn't agree more.
Go ahead.
No, I couldn't agree more. That was what I was going to say. Just validating.
And I'm going to validate too. And I'm just going to say just two things. One, I think the beauty about being on the front end of a coalition, as we are, we kind of build the ship as we're sailing it, which is actually really good, because we're learning. The coalition itself is learning. Remember that culture of the coalition. We're learning in terms of a best practice on how we can best get the best out of that coalition. Remember, Becca mentioned that feedback that we gave to ourselves around kind of like how do we best the QI around that, and how do we best deliver this out to researchers. And so I think the good is to be on the front of that, because we're learning, we're documenting our progress along the way so we can best, so I would echo what Becca said and Caroline said. I think there are no bounds right now. I think, but the beauty thing is make sure we are in the best position to, whenever someone that comes before us, that we're not with the big traditional research, are that we're in the best position to get them feedback.
Mm-hmm. That's great. Well, hopefully it's, others are hearing about it. I know I'm excited and might be reaching out to you guys myself. But, what are some of the biggest mistakes or biases that perhaps you're seeing kind of over and over as you're reviewing research projects that researchers are making? Caroline, I know you talked a little bit about assumptions earlier. What is it that you're seeing? Are there any kind of recurring themes?
I'll just jump in again, and this is a good one, Becca and Caroline, so we can think about this, but I'm just going to get it jumping just because I don't want to, I think one of the things, again, that we're seeing potentially as a theme, and it's not, maybe it's just out there, is the clarity around your dissemination plan. And again, when we have these researchers come before us, again, it's so critical. If you have a dissemination plan, now some researchers, they aren't there yet, that's fine. I'm not talking about those, but the ones who have a dissemination plan, have you thought about really engaging the community and partners and things like that with the dissemination plan to make sure the plan can be sustained? And I think this really helping the researchers think about the reach of their dissemination, and I think there's needs to be thought into that. And that's also what Caroline was speaking earlier around when we work with the researchers on the front end, helping them think about who your partners are, roles that are appropriate, roles that kind of are kind of entrenched in the communities you want to reach to. And that helps the dissemination plan as you engage those partners to actually now get to carry out this plan and sustain it. So that's one thing we're seeing, some of the weakness in the dissemination plans.
Oh, great. Thanks for sharing. And so, maybe I'll just wrap up and ask Becca just one more question. What lessons have you learned, or really any of you, about establishing a coalition like this? And do you have any advice for us as we kind of think about trying to set up a similar one?
So one thing we haven't talked about yet, I mentioned it very briefly, is all the work that we did up front to really build a cohesive group and how important that was. I think that's what makes this unique compared to other mechanisms I've seen of giving community input on research, is we spent a good amount of time up front kind of level setting, for a better that term I think is what I would use, making sure everybody felt confident asking questions about the different types of research terminology they were going to hear, learning from one another. We've really emphasized learning from one another. So when we were doing a genetic study, lifting up the experience of one of our coalition members who'd help recruit for all of us and tell us her perspective and also the researcher perspective. So I think finding those opportunities for learning from other coalition members, building a collective identity of the coalition, having them co-develop this rubric. And so it really feels like there's ownership. So it doesn't feel like there is ownership. We went through this process of developing it together. And so I think all that upfront work of really having the group gel, be a trusted entity, and this observer researcher role that Karen mentions in the video, of having an opportunity in every meeting at the end to have the people who were in that observer role say, boy, when you said that was like amazing. I loved how you put that. Like having that feedback for one another that's really positive, and also being able to process maybe some of the harder parts of that particular review just builds us as a group together. And I think that's just been phenomenal, and I really encourage others to do that.
And may I add something? Do we have like a second to add? So
go ahead.
Rebecca usually doesn't give herself any credit for the actual work she does. In order to have this project moving along and this coalition being functional and effective, you need a strong person on the backside, like Rebecca does, to keep us as a moderator, to keep us moving along, to streamline thought processes, to gather information that's relevant, to assign roles when, you're the one who's going to do this, you're the one who's going to do question 2. So when we actually meet with the researcher, she's like the coach. She's already lined up of who's going to be speaking, in what order, what are we going to be saying. And I think that that's a critical role. Otherwise, believe me, each of us has so many things to say that we would spend days not having any concrete thought on what we were going to actually deliver on, because everybody has such an amount of intelligence and life experience, and everything is so relevant that you do need that one person who's that funnel, who is able to gather everything, synthesize, make it strategic, give it an order, and then make the coalition deliver it. So she never gives herself credit, but I always make sure that we give her credit, because her job is, I think, critical. And since you're kind of like thinking of replicating this, you need a person like Rebecca. You need your own Rebecca, a different Rebecca.
I know. I was going to say, we need a Jerry, we need a Rebecca, we need a lot of folks from the wisdom that we've learned here today. Well, I just want to say thank you all so much to all of you, our amazing panelists, for such a rich discussion today. And I know I've certainly learned a lot, and hopefully our audience members have as well too. So thank you so much. Let me turn it back to you, Anna.
Okay, so that's it, everyone. My brain is full. My heart is happy. Thank you for everyone who is still with us. A summary of today's summit. and recordings of the sessions will be available on our website. So watch your email for when they're posted. For anyone interested in the continuing education credits, you will receive an email in the next 48 hours with the link to complete an online evaluation. Once you complete it, then we can issue the certificate of completion. If you have any issues, just let us know and we'll get you squared away. Thank you again to our sponsors and to our wonderful, wonderful hodgepodge of coalition staffers, Kareen, Jane, Samawa, Diane, Zuleika, Yemi. You guys are the best. And of course, the bestestest is the incomparable Stephanie Chan. I am so fortunate she chose to work with us. We are so lucky to have her. Thank you, Stephanie, for today and for everyone and for everything. And farewell to all of you friends. Thank you for coming and hope to see you in person the next time. Bye.